All right, well, great. It's wonderful to be here, and I'm very impressed by the number of people who've come to dedicate your day today to meeting and learning about the stuff that myself and other speakers are going to talk about. It's also a privilege to be here because I know a number of people in the audience. Some of you have been working with actually some of you were dental students when I was teaching you in dental school. So it makes me feel a little bit old to see that you're actually grown-ups now and doing wonderful things out in the world, but that's the way the world works. I feel the same way every time I go visit my grandchildren, so that's what happens. So what I'm going to try and do in the bit of time I have, I think it's about a half hour, and I'm going to try and take a little less than that to see if there's a little bit more time for some discussion afterwards. But I'm going to try to present what I think for some people is going to be a fairly different vision of how do you create oral health in a population of people who have difficulty having oral health. We have a traditional dental care system that's been doing it a certain way for really forever, and we have some new opportunities now. So that's what I'm going to talk about. A little bit of background, and then we'll get into what the new opportunities are. So the title here, Update on Virtual Dental Health on the Road to Value in Oral Health Care. Let me just say something about this idea of value. You've heard even already several of the people have already talked up here have used the word outcomes and try to improve outcomes. And we're actually in an era now, I have referred to this as the era of accountability. This is throughout our healthcare system where there's more and more attention being paid to what happens as a result of healthcare treatment. We've, for a long time, have had a healthcare system where providers were paid to do things to people, mostly do things to people, not necessarily do things to people, and got paid for the things that they did, not necessarily based on whether those things actually did any good or people were healthier or saved money or anything else like that. But we're past that era now. We're really in an era of accountability where people who care about health outcomes, people who are paying for health services realize in the United States we spend far too much money and don't get nearly good enough results, particularly compared to most of the other developed countries in the world, and much more of a focus now on being able to shift our thinking to producing better outcomes, often referred to as value. So my formulation of how do we get there, how do we do this, I think in terms of the oral health world, although this is not too different than other aspects of healthcare, it involves these three things. That we're moving now towards a system where we're developing better ways of measuring health outcomes. In order to be able to say you're actually improving health outcomes, you got to know what you mean by that. So you have to develop definitions and measures and collect data. But that's already beginning, much further along in general healthcare, but it's well on the road. I'll give you a little bit of information about that in a minute. Measuring and providing incentives for providers to actually focus on producing the best health that they can at the lowest cost. We've got some spectacular new, what I referred to here as prevention and behavior support science, which I'll talk to you about in a few minutes, that allows us to really think differently about how do we improve the oral health of populations. And finally, we have some different ways of what I call here delivery systems of actually getting to people who traditionally don't get dental care or don't get it until it's pretty late in the game. They've already got lots of problems by the time they reach. So we have some new ways of thinking really about all three of these things, which are really the key ingredients towards producing value and producing a value-based healthcare system in oral health. So start with the fact that most people in our country are not getting dental care. Now that may seem, I don't know, for some of you that may seem obvious, for some of you it may seem surprising. Often people who don't have trouble getting dental care have trouble realizing the number of people who don't get dental care. This is national data, so it may not be exactly the same here in Santa Clara County, but national data broken down by age group, looking at populations that have what's called an annual dental visit. That means they interacted with the dental care system once during the year. Now, that doesn't mean they had great dental health or that they got all their needs met. It just means they interacted with the system once during the year. Even by that very low bar measure, it's less than half the children. In the last couple of years, it's bumped up to around 50% of children. But half the children have even an annual dental visit. Only about 40% of seniors and only about a third of working age adults. So if you did the math, and I'm nerdy enough to have done it, if you did the math, what you come out with, that's 188 million people who are not getting dental care. About 60% of the population of the United States is not getting dental care on any kind of regular basis. And if you look at who's getting dental care in our country, it's overwhelmingly the more affluent people, more affluent parts of the population are the people who are actually getting into dental offices and getting dental care. And those are the people who tend to have the least amount of disease, where most of the disease is actually in the mouths of people who are not getting dental care. So, the conclusion from that, we have a dental care system that's primarily serving the wealthiest and healthiest segments of our population. We also have a dental care system that's really focused on sort of surgical repair of disease. You could say this about our entire healthcare system. In the United States, we have much more of a disease repair system than we have a healthcare system. most of the money, almost all the money goes into disease repair as opposed to creating health for the population. And yet there's increasing understanding of what some people are calling now the social determinants of health. This slide is from the California Department of Public Health's website, and it just lays out in a nice way. I like the slide because it shows all the different things that impact whether people have good health or not. Everything from social inequities, institutional inequities, the way people, laws and regulations are set up, living conditions, whether people are living in food deserts or even have access to services in their neighborhood. Healthcare is right there. One little circle here is healthcare. And yet there's now increasing understanding that all these other things actually have much more impact on whether people are healthy or not. So we tend to focus, certainly all the money is in healthcare, but there's increasing recognition we've got to actually shift that balance. So all that has resulted in a national goal for our healthcare system, often articulated as what used to be called the Triple Aim, and now it's gotten one more part to it, so it's often referred to now as the Quadruple Aim. And that's a goal for our national healthcare system that's often used by policymakers and applies to dental care as well. And so the goal is to figure out how do we have better outcomes, have people have better oral health, how do we lower the costs of providing oral health so you have lower least cost per capita per person, and at the same time, how do you improve patients' experience? And then the fourth one that's been added recently is a recognition we're not going to actually do very well unless we also improve providers' experience in the healthcare system as well. So that's now called the Quadruple Aim. Again, my view is the way we're going to get there is through these three things. So let me say a little bit about each of these areas that I think are really the path to, or as the title said, the road to producing value in the oral healthcare system. So first one is measurement and payment. I won't say very much about that other than the fact that there are lots of very important groups in the oral health industry that are working on this, working very hard at it actually. The American Dental Association has something called the Dental Quality Alliance, which is producing measures that can be used in evaluating healthcare systems. Many payers, people who are paying for dental care, whether they're private benefit companies or government programs, are working very hard at how to understand how to measure and provide incentives for producing a healthier population as opposed to just paying for doing stuff. The HRSA and the healthcare system, the health center system are probably the furthest along in the industry of actually having measures and providing incentives for them. And lots of group practices are now beginning to have internal measures. So although I think that many people who are in the oral health industry you start to talk about this and say, what are you talking about? There's no value-based measures. There's nothing that applies to the dental practice. We do what we've always done, which is we do things, we get paid for the things we do, as opposed to, but I think that's probably a little short-sighted. I think we're moving rapidly into an area where there's going to be a lot more focus and incentives based on health outcomes. Okay, second point is prevention and behavior science. When I was in dental school in 1923, well, it wasn't quite 1923, but a while back, when I was in dental school, particularly you had a tooth problem, there was really nothing a dentist could do other than reach for their handpiece and drill out that part of the tooth and put some kind of artificial material into the tooth. And now we have a bunch of new technologies that can actually really make a difference in terms of how do you treat something as fundamental to oral health as tooth decay. Here's just a smattering of some of the things on this slide. I'll delve down into some more of them in a little bit, but things that foster what's called remineralization or repairing of the beginning to dissolve enamel can actually be remineralized. Buffering agents that can change, and you don't have much saliva in your mouth, like I don't at the moment, so I can take a drink. Oh. Actually, I'm just getting over a little bit of a cold, so I've taken a decongestant that has my mouth be very dry, so I have to be drinking a lot now. Caries resting medication, I'll talk about this in a minute. One drop of this new liquid can actually stop the progression of decay on a tooth. And a new idea about sealing caries. Again, when I was in dental school in 1923, the idea was that if you had any decay in a tooth, you had to remove all of it, even if that resulted in injury to the nerve in the tooth, even if it resulted in what's called a pulp exposure, even if it led to needing a root canal. That was the only thing you could do. And now there's very strong science that not only don't you have to do that, it's actually wrong to do that. It's better to leave some decay and seal it in place. So fluoride varnish is, for those of you not familiar with it, is a liquid that can be placed on the teeth. Some say 3 times a year, some say 4 times a year. There's good data, even once or twice a year can make a big difference in reducing the amount of decay. And if teeth are already beginning to dissolve before a piece of the tooth breaks off, you can actually remineralize the tooth with this liquid fluoride varnish. Silver diamine fluoride is the thing I mentioned a minute ago. once part of the tooth is already broken off and you have some decay, an actual hole in the tooth, you can actually keep that decay from regressing with one drop of this liquid. It has some disadvantages, and it turns that area of the tooth sort of a dark color, but still, one drop can stop the progression of decay. We have, for a long time, have had dental sealants, and those probably the best evidence of any kind of procedure we have in dentistry is dental sealants in terms of ability to stop the progression of decay. And now there's a technique which is available here in California. It's available because we did a 6-year demonstration of the ability for dental hygienists and dental assistants to be able to use this technique. So now it's available. It doesn't have to be just a dentist, but allied personnel can actually do this in California, which is a technique that relates to this idea of sealing caries. I'll talk a little bit more about what happens with that little tooth, with that little hole, and the ability to seal that in place without any drilling, without any anesthetic. And the great thing about, I'm sorry, one more thing before I get to the great things. So there's even evidence that when sealants first came out, the idea was that they were supposed to seal grooves in teeth where decay might start. But a lot of dentists were taught, but you never would want to place one of those when there's already some decay, or if you're not sure, maybe there's some decay, you wouldn't want to place a sealant. And now it's known that that's not even true. That even if you actually know there's decay underneath one of those grooves, this is a 7-year study, looking at actually sealing an area where they knew there was decay underneath, nothing changed. The decay was sealed in place. Basically, you're starving the bacteria to death. If you isolate them from the oral fluids, they stop being fed and they just die or become dormant. All right, so we have this great new tooth technology. One of the great things about that, everything I've just talked about are things that can be done by allied dental personnel, take for example a dental hygienist, in a community setting like a Head Start center or a school. They did not require a dentist, they did not require a dental drill, they did not require a dental office. And so it opens up a whole new era of being able to solve a lot of dental problems in community settings where you can bring care to where people are instead of requiring everyone who needs any kind of dental care to go to often very difficult to access dental offices, and people have lots of barriers getting into dental offices. All right, so that's one area. I call that new prevention science. Another thing that's beginning to revolutionize our thinking about dental care is sort of rethinking what diseases we're actually dealing with. So it says here, care for chronic oral diseases. The idea here is that we actually are realizing the major diseases that dentists deal with, or the dental care industry deals with, is dental caries and periodontal disease. And these are both chronic diseases. So what's a chronic disease? Somebody name a chronic disease. I heard high blood pressure, I heard diabetes. So if you have diabetes and you go to your physician's office, is your physician going to fix your diabetes today? No, that's actually the definition of a chronic disease, is a disease that's going to continue over time and maybe help you manage the disease with some medication or some diet counseling, but the disease is going to continue and it requires a sort of a partnership between the provider and the individual to be able to manage that disease over time. So if somebody walks into a dental office and they have a hole in their tooth, and the hole got there, how? The hole got there because of this caries disease process, which has a lot of components to it, but sugar and bacteria and acid production and all those things. The dentist puts a filling in the hole in the tooth. Has the dentist cured the dental caries disease? No, they haven't actually. What they've done is just fix the symptom of it, which is the hole in the tooth, but they actually haven't cured the disease. And yet, we have a system where we call that filling treatment. We pay for that filling as treatment. We don't pay for managing the disease. So there's a realization that we're dealing with chronic diseases, and there's a really well worked out system called chronic disease management, which is for diseases like diabetes and heart conditions and things like that. And we really ought to be thinking more about how do you use these principles of chronic disease management in terms of managing dental disease. So as an example of the idea of chronic disease management, when you ask, what are the things that actually keep people healthy? What leads to people having long, healthy lives? There's been lots of studies and sort of a meta-analysis where they combined a bunch of data, came up with this pie chart, which is the number one thing that has people be healthy or not is behaviors. This is individual things that people do by themselves, for themselves every day. This is, do you smoke? Alcohol? How much alcohol do you consume? What's your diet like? Do you exercise? Do you brush your teeth? Do you use fluoride products? All these things are things that people do individually every day. That's the major contributor to health and a major contributor to oral health. I know a lot of, how many of you are dentists in the room? And dental hygienists? So it's not the majority of the room, most of you are not, but certainly dentists and dental hygienists know very well that there's a very limited things that the dentist or the hygienist can do absent person changing their individual behaviors on a daily basis. So the major thing that has us be healthy is individual behaviors. Genetics accounts for about 30% of it. Right now, there's not much you can do about your genetics. Some people say you try to choose your parents very carefully, but that's hard for most people to do. There's about 20% of what keeps us healthy have to do with things we can do something about as a society. This is, no smoking in restaurants and seatbelt laws and things like that. But the interesting thing here for me, the most interesting part of this chart is only about 10% of what keeps us healthy is procedures performed by healthcare professionals, whether it's physicians or nurses or dentists or hygienists, only about 10%. And yet if you were to redraw this chart based on where the money goes, what would be the biggest part of the chart? Almost all the money goes here into paying for professionals to do procedures. So this opens up a major opportunity, once you understand this, to rethink how do you have a healthy population, which is to focus on supporting people adopting healthy behaviors. And that's not easy to do. It's actually very difficult to do, and there's lots of data now and understanding more than there used to be about how do you actually get people to adopt healthier lifestyles. One thing we know is that a dentist or a hygienist giving what I call, our dental students are all trained to do this, the speech. Remember the speech, many former dental student. So every dental hygienist and every dentist knows how to give the speech about what you should be doing. But it turns out that speech does very little good. Most people don't change their behavior based on the speech. The speech is an attempt to provide some information. Most people actually know you're supposed to brush your teeth. It's usually not news. How many of you think that you exercise as much as you should? There's usually a few exercise fanatics in the room. I see one or two hands back there. All right, for the rest of us, is it because you've never heard that exercise is a good thing? No, of course it's not. So we know that just giving people information isn't enough for most people to actually make significant changes in their behavior. So if you realize this is the most important thing we can be doing, what are the things that actually make it more likely that you're going to be able to support someone in adopting healthy behaviors and lifestyles? Well, this is a list of things that are known to make a difference. So one is multiple messages delivered by different sources. So if you hear the same thing from a bunch of different people, you're more likely to do something about it than if just one person tells you. Messages delivered by trusted members of the community are more likely to have you adopt a different behavior. So there's good studies that show that people think that dentists and hygienists are very smart and we have lots of information and we don't understand their lives, so that they tend to discount things that we say. It's like the little thought bubble. Here's the dentist talking to the patient, and the dentist is giving the speech, and the patient's nodding and smiling, and the little thought bubble inside the patient's head is, you don't know what it's like for me when I take 3 buses to get home. At the end of the day, and I'll just do anything to get my kid to sleep, even if it means putting him to bed with a bottle that has sugar, and I know that, but that's what's going on inside the patient's head. In the meantime, they're nodding and smiling, but they're not actually adopting the behavior. So it turns out the messages delivered by people who are your peers are much more likely to actually have you take action than something delivered by a professional. Of course, everyone saying the same thing can certainly help. Messages targeted to people's values. There's a whole technique called motivational interviewing, which is actually helping people to elicit what are people's values, what's important to them, and then providing information based on what's important to the individual. So most of us don't like to be told, I want you to do this because I want you to do it. It's more like, how can I help you do what you want to do? And it's a whole different way of approaching the conversation. But I think these last couple of things were really very telling. It's messages that are repeated over time. So you ask someone to try something, you come back in a few days, say, hey, how did that go? Or you try to break things down into small, tiny habits. So a mother's putting their child to bed with a bottle that has milk in it, and you know that's got sugar in it, and that's going to lead to tooth decay. And you say to the mother, why don't you try just putting like 10% water in the bottle tonight? And 2 days later, you say, hey, how did that go? And the mother says, well, the child didn't seem to notice a difference. Great, why don't you try a little bit more dilution? So that tiny habits reinforcement, and that's something you can't do in a dental office. You're not seeing people on that kind of regular basis. And then ongoing reinforcement and coaching and peer support. The point of this whole list here is actually we can do a much better job of encouraging and supporting people to adopt healthy lifestyles if we partner the oral health industry and oral health professionals with people who are in regular contact with the population we're trying to support and actually coach and support those people to actually do the messaging. It's much more likely to be effective, which means bringing dental care into communities and integrating dental care in with community organizations. So I'll get back to that in a minute. All those developments I talked about before are kind of the basis for why we began to think about different delivery systems. How can we actually bring dental care to people? How can we apply these principles of new prevention science and behavior support science to improving the health of the population, actually achieving the quadruple aim. So I'm actually going to skip a couple of these just in the interest of time. And the thing we came up with is a system that we've been now working on for, it's getting close to 20 years, called a virtual dental home system. Say just a bit about the name, virtual dental home. So it's really all the rage in the healthcare system these days, referring to home, the home concept. Used to be medical homes, now they're called health homes. And in certain specialties, it might be, a dental home. It started out with the idea was a medical home, which was going to be the primary physician's office, where you would try to make sure you're getting people to get the services they need, make sure they're keeping the recall visits that they need to come back and have something checked on, that you're helping people understand their own diseases and helping them manage their own diseases. If you look at the literature about in dentistry, the term dental home almost entirely refers to the bricks and mortar physical dental office. And so what we wanted to demonstrate was that we could provide all of those home support concepts, but do it in the context of what we call a geographically distributed telehealth connected team. In other words, different people in different places working together, connected through a telehealth system. That was the goal of the project. So basically how it works, some quick pictures to illustrate it. This is what we call a community team. It's a dental hygienist and a dental assistant. They're in a community site. That's all portable equipment they can bring into the car and set it up in a very quick amount of time. Doesn't take up much space. This is in a Head Start center, just pushed one of the bookshelves aside. You can see all the equipment that they have. They're not delivering full service dental care, so it doesn't take a lot of stuff. And they're collecting a full set of images. This is x-rays. That thing is not a hairdryer. It's actually a little dental x-ray in it. And we're using digital sensors now. It's not film anymore. And photographs. This is a photograph of the teeth. You can see the tooth picture on the laptop back there. So collecting what would be a full set of dental records, everything you expect to see in a fully populated dental record chart in a dental office. And all that information is going up into a cloud-based electronic record where a dentist who's not on site, the dentist is not in the Head Start Center or the school, but the dentist can get into those records, review the records, decide what needs to be done next. And the basic decision is this patient healthy enough so that things that need to be done can be done by the hygiene community team, or do they have to come see a dentist at least for some of the treatment? One of the things that's now a new tool, as I mentioned earlier, is this idea of these interim therapeutic restorations. Again, no drilling, no anesthetic, can be done very quickly and easily and painlessly in a school or Head Start center. This tooth with a small hole in it, what typically happens for children, well, like the one whose this tooth belongs to, is nothing happens, actually, until that hole becomes a bigger and bigger hole, and then the child is in school with a toothache and not learning, or they end up in the emergency room, or when a bunch of teeth get into that situation, they end up in the hospital. And now in about 10, 15 minutes with, again, no drills, no anesthetic, no shots, that decay can be sealed in place and put that child in a holding pattern for a long period of time, actually many years. So we did a 6-year demonstration of this idea across California, 13 communities, 50 sites. We were clearly able to show that this idea of telehealth connected teams could work. People could work together in different places and communicate through a telehealth system. Some high-level outcomes from that 6-year demonstration were that we could reach people who are not getting care. We could lower the costs of delivering services. The majority of people could be kept and verified healthy on site. About 2/3 of children, actually, low-income children, Medicaid populations that typically don't get much care, 2/3 of them could be kept healthy on site with the community team, the hygienist and assistant being the only ones physically touching them. Only about 1/3 needed to get to a dental office. And even those 1/3 that needed to get to a dental office were much more likely to go and get the treatment because they'd already had a full diagnosis. They weren't going to the office for an exam. That had already been done. They had all the preventive stuff that had been done ahead of time. They're only going for a couple fillings. It's much more likely for them to show up and get that service done in that kind of environment than when people do typical screenings and lists of referrals. Much less likely that they're actually going to follow through and get full care done. So as a result of that, there's now payment systems in California through Denti-Cal and through our health center system. This system has been expanding. This is a quick example in San Mateo County, your neighbors to the north. There was one health center in San Mateo that we started out with in 2010. Had one site, one Head Start center, one hygienist working a couple days a week. They've really, Ravenswood Family Health Center, they've really systematized this, figured out how to do it. They've now got this little van where they're used to go to sites. They put their portable equipment in there. They're really quick at setting things up. They can collect the records. They can have the dentist review those records. It's not real time, it's sort of store and forward. So the next time they come back, they're able to do procedures. And because of this, they're now working in 27 different sites across San Mateo County. So it's an example of how an organization that learns how to do this can greatly expand the reach of this kind of system. there's a learning curve to it, but we're starting to see adoption even across the United States. We started out doing this in California in 2010. By 2014, we had funded projects to replicate the system in California and Oregon, Colorado, and Hawaii. In 2018, we're working with a number of other states that are beginning to do this. And now in 2019, many more replication states are doing it on their own. We're in discussions with people really across the country. So you can see this is actually expanding almost exponentially. I think this style of doing care is going to be really a very big part of the dental care system in the future. Now, there's a learning curve to it. It's not easy to do. This is actually just what's called a dashboard. It has a bunch of columns in it of things that we typically work with entities when we're trying to help them learn how to do this. It's got things like figuring out all the regulatory environment. What do they need to do to get ready to do things and be able to bill for it? What equipment do they need? What kind of electronic dental record system they need? How do you set that up for a distributed environment? What kind of IT system? How do you establish connectivity in the community? What kind of agreements do you need with community sites? How do you set up a workflow so you can actually integrate care into a school, for example, and make that connected to a dental office? Things like, that's not what I meant to do. Things like an enrollment process. How do you get people signed up? We have very high enrollment in these systems because we have the schools or Head Start centers we're working with become very much a partner in it. It's not like they're saying there's an empty room, turn the lights off when you're done. They're very much a partner in making the system work. So getting people enrolled, how do you do all the clinical workflow and patient care? But all this is leading us to a point where we really now are able to rethink, I think, the idea of a dental practice. I call it now the community-engaged dental practice, a realization that dental care is a team sport that takes a lot of people, actually, to do it well. We can rethink the idea of a dental practice. Instead of thinking we're going to do some stuff in the community and then some people get referred to an office, but they're really pretty separate. We can actually think about them all being one practice. So you can have a dentist who are part of the team is in what I call the high-cost surgical suite. That's the dental office. Part of the team's in the community, but it's all one team working together, doing things that the lower-cost things can be done in places like schools and Head Start centers where you can actually engage populations that don't normally get care, and then every once in a while they need to go to the surgical suite for some more complicated surgical interventions, but that's not where the primary care is, and the primary care is done in the community. So dental care in the future, I think, this is an example of a dentist with data gloves and patient in a machine, which is not here yet. You can't buy one of those things yet, but maybe at some point. Now, I think what's going to happen is you're going to see a lot more of this idea of dental practice, including geographically distributed telehealth connected oral health teams. We're going to start shifting our focus to using the principles of chronic disease management, biological, medical, behavioral, and social tools. This is going to allow the dental industry, and already is beginning to in places that are doing this, to interact with the majority of the population, which we don't do now as an industry. And it's going to actually help us and even being driven further as we get further into this whole era of accountability. So I think these are the golden rings in terms of the future of oral health care, figuring out how do we incentivize providers to focus on producing healthy population and do it at the lowest cost. How do we have a delivery system that actually reaches people? And then when we're in contact with the population, how do you actually do things that use the best science to be able to produce the best health at the lowest cost? And most importantly, is to foster people adopting healthy lifestyles, which is the most important thing that has people be healthy. So that was a quick run through with a lot of complicated ideas. I think I'll just say stop. I'll stop and say thank you for the moment. So. And then I think we have time for some questions, yes?
We're going to ask, we have cards, and if you have questions, and since I don't have any cards yet, I get to ask the question.
Okay.
So how difficult is it to convince parents to do the dental care at the school site? Do they feel like they have to be there, or are they pretty accepting?
The system we've been using is one where the parents don't have to be there. So it's actually done with consent. They have full consent, but the consent's given ahead of time, and so the parents are not necessarily on site when the care is given, but there is always feedback to the parents about what happened, and particularly much parent involvement if they need to go to a dental office or have something else done. How hard is it to convince them? Sometimes when you're first starting to do this, we found that people are not so sure about it. It's, there's a very dominant paradigm in both the lay population and the profession, which is that dental care happens by people picking up the phone, making an appointment to a dental office and going, that's what dental care is about. So to have people understand that this is a different style, typically what we find is maybe we have a little slow uptake in the first year. By the second year, people are beating the door down to be a part of this process. When parents get the idea, I don't have to take a day off work, which is really is difficult or impossible for some parents to do that. I can actually have my child have their regular checkups and preventive service at the school. There's no arm twisting. They really want to do it.
Great. And then how do we find dentists that are using new dental procedures and treatments? So I think this is a question like, do you ask the dentist if they do the ITRs?
I'm not sure if the question was, how do you find dentists who are involved in a system like this? The question was actually, we're using new treatments. New treatments can mean a lot of different things, but certainly some of the prevention science, the idea of sealing caries and using interim therapeutic restorations for small holes in teeth rather than drilling on the tooth, using sealants, using silver diamine fluoride, those are all things that you could ask dentists about how they treat decay. Finding a dentist who uses this system, that would be tough because it's a beginning. We've been doing this for almost 20 years, and I think we're in the infancy now of seeing it spread. You saw San Mateo County has a lot of places that are having care like this, not much in Santa Clara County. So I think my prediction is in the future this is going to be everywhere, but we're not there yet.
And then there was a question about, could we send out the presentation to everyone that's here? Are you
yes.
all right with that?
Yeah.
Okay. And have the dental teaching programs focused on these new protocols to prevent variations in practice?
I'll give two answers to that. So one is the new prevention science. Yes, that's taught in every dental school. But sometimes students are getting mixed messages that they have a lecture where someone talks about the new prevention science and things like sealing caries, and then they'll go into the clinic and they'll have someone who's a faculty member who actually is in practice and is only there volunteering a couple days a week and says, no, don't do that. Here, you just need to do a regular filling. So students are still getting mixed messages really across the country. I've talked to people in a lot of dental schools. In our school, the same thing. So we still got a ways to go before we fully incorporate this new science and new ideas into dental care.
And then are you having success getting primary care doctors to do fluoride varnish treatments? I believe in our county, it's done at every well care visit. Is it, Greg, it's here maybe up to 5 or 7?
We do them in pediatrics.
Up to the age of 5 or 7, I believe.
Yeah, it's been interesting. There have been some studies about physicians are certainly allowed to do it. They're paid for doing it under the Medi-Cal system. There's some other states that have a lot higher uptake for physicians doing this. And I've looked at some studies about what the difference is from state to state. Some of it has to do with how much money is paid for it. So states that allow a higher fee for that actually get bigger uptake. It's not necessarily one-to-one. It's not just money, but that's one of the factors. So it's allowed and it's happening, but it's not as widespread as it could be.
And what role can non-dental professionals, volunteers play in getting your points more widely found in the communities?
Well, certainly the idea of encouraging and supporting the idea of dental practices and dental professionals partnering with community sites and figuring out and supporting people in terms of how do you make an arrangement with a Head Start Center. I think every Head Start Center in every elementary school should have a dentist, at least a dentist and a hygienist who's kind of their consultant, who's there for that school, who helps to educate the teachers and in Head Start. Even if you're not doing a full service dental care system like this, just to be able to support the family advocates. Head Start has this fabulous system of family advocates who are the people actually in contact with the parents who have the best job of influencing parents' behavior, and often they don't talk to dental professionals. So even having dental professionals have a regular set of meetings with the local Head Start Center can make a difference in terms of changing people's behavior, which, as I've said now several times, is the most important thing that can happen.
Great idea. What happened in San Mateo County that helped them to become early adapters?
Yeah, I'm not sure the answer to that. I mean, they were one of the first sites we started working with during the early demonstrations, so they've been at this for a while. They've been at it for almost 18 years now, and it takes a while. As I said, there's a learning curve. This idea of having a full service telehealth connected team system in place, there's a lot to it. I showed you some of the things that are to it, and so they've had some time to develop it. We're seeing that happen in other places as well, is that over time, people get the idea, they figure out how to do it, and it begins to grow, and I think it's just going to continue to grow.
And this one, does your program also come to Santa Clara County schools? How do children get care if we do not have insurance or are undocumented? And I do want to answer the second part because 98% of the children do have insurance. Right. And this county works very hard to make sure they use their insurance to get the dental care. And those 2% that don't have insurance, we work very hard to get them insurance. I don't think Healthier Kids has found a child in 4 years that we couldn't find a way to get insurance.
That's great. And we're working with actually some providers in Santa Clara County about beginning to use this virtual dental home system. So again, I hope it'll start to spread and be more in evidence here. And certainly if anybody is in a position to want to talk about how to foster that or speed it up, I'd be happy to have those conversations.
Yes, I believe Indian Health Center is already going out virtual. Okay. Let's see. In the golden ring slides, these diagrams often show a connecting concept that is common to all three ideas, but your diagram has no common area.
Well, I think the idea of that diagram was to show these are all essential ingredients. I don't think we're going to get very far by just doing one of those things. I think that you can have a great delivery system, but if you're not using the best science, you're not going to accomplish very much. You can have a great delivery system and good science, and if the incentives are all to do something else, you're not going to accomplish very much. So it's really the combination of those three things that's really going to get us where we need to go in terms of producing real value-based oral health care systems.
Okay, and I have one last one. I'm hoping I can understand it. Medi-Cal reimbursement to the dental team, I think they're saying, is very low. Is there any reimbursement available to Head Start or child care or pre-K that you know of?
Well, Medi-Cal pays the dentist, so no, the answer is no. There's a pilot project now, the Dental Transformation Initiative, that's providing some funding for care management or care coordination as a part of a 4-year test of some different ways of doing things, but the payment doesn't go to the community sites. It's really going to the dental practice. I thought where that question was going to be leading to was the idea of Medi-Cal payments being so low that many dentists are not willing to accept Medi-Cal. That's been an issue, that most dentists actually don't accept Medi-Cal. The majority don't, and even some that are listed as accepting Medi-Cal might only see one patient a year, so the majority of patients are certainly not have any significant part of their practice with Denti-Cal. But what we're finding is with a system like this, the reason the dentists don't accept Medi-Cal, number one, the fees are low. They're working in a high-cost environment. A dental practice, this high-cost surgical suite that I've called it, is a very high overhead business. 70 to 80% of the money that comes in goes right out again in terms of paying salaries and bills and buying materials. And if you're getting paid 30 cents on the dollar, well, the math is just not there. You're going to be losing money. But what people are beginning to realize is if you think about this community-engaged practice, and you have part of the money is, or part of your practice is in a low-cost community environment, you can actually lower the total cost of the practice, and it becomes more feasible to actually accept patients with a lower payment rate. So that's beginning to change. People will be more aware of the changing economics of dental practice.
Thank you, Dr. Glassman. And will you be here for a while for other questions?
Yes, I will.
Great. I met Dr. Glassman at the State Dental Board, and he was the best part of my 5 years at the State Dental Board. So thank you for doing this.
Thanks for the opportunity to be here.